What we want is to almost evangelize, so for you to go out and tell those colleagues who don't take photographs, they need to take photographs. And that's also even GPs. Okay? GPs can also take photographs and do right by their patients. Okay? So people outside skin cancer practice alone. Okay? So we want you to spread that message. So that's one of the reasons we're telling you. The thing about case law is that case law is dynamic and not static. So the fact that it hasn't happened so far doesn't mean that it won't happen. But as Jeff says, you get judged against your peers. And our peers, by definition, are general practitioners. Okay? Because there is no specialist area of skin cancer with general practice. So you're being compared with people who don't take photographs, who do low-level skin cancer care very often. Okay? So the burden of proof to convict you of anything is very low. So please do not be scared to image things, because on balance, vastly, abundantly, you'll be helping people.
I'm very interested in the Apple TV because I use a Molmax at the moment, and I have it streamed onto 2 large monitors on the practice, and we're showing the patients as they go and explaining and demonstrating that we actually know something about skin by describing their SEPKs to them and describing any angiomas. That's something they actually never had a little bit of information get given by their GPs. We usually sort of say, oh, that's nothing, don't worry about that, that's nothing. And patients actually want to know, and you can show and demonstrate that. I mean, they think that you really are doing the tolerance well. They don't say that I am. But what I mean is that they really do get an idea of what your level of expertise is. So I really hope that that's going to be something that's going to get rolled out with this. And the other thing that's really good with those kind of things is when you've got that image, you're trying to get consent for a complex procedure, then you can actually, I use the plastic overlay, you can actually draw your procedure on the image of the patient's face, and what you're going to do with this VY flap or this H flap, and it really gets very good informed consent even if it's not written. And lastly, when and how are we getting this?
Okay, so in order, Apple TV, not that it will be rolled out, it has been rolled out. It's actually up and running on the walls in my clinic, and it does work exactly as you say it works. I use it exactly the same way. I can point out the most benign little feature, and once you point that out, then you can see the patient visibly, physically relaxed because they then have confidence in you. Okay? Very powerful. For the second point of drawing out the procedure you're going to do, if you want to be technological about it, what you can do very easily with literally a click of a button is to download this to PDF, and you can have PDF viewers and drawers. You can actually draw on a PDF if you want to do that, that the patient can look at on screen if you want to do it that way, or print it if you want to and draw on it. You can do exactly that technologically. How are we going to get this, and when are we going to get this? Well, the idea was to wait for this seminar now to explain and put the basis down for it, but it is essentially ready to go. So we can roll it. The idea is to roll it out from now to our practices.
I was just going to say 2 other very useful aspects are that you can, just as you can drag and drop photos into the system, you can also drag and drop them out and then send them to, say, a local plastic surgeon or Mohs surgeon. They can triage the patient, they can find the lesion you're talking about. The other thing is if you're ringing a patient who lives 600 k's away, as often happens to us in Adelaide, and you're trying to remember which of the scaly plaques on which ankle you've seen, and you're ringing them with results, you can actually talk to them about the options over the phone and pre-plan things. So it's very large and you would normally refer that on. You can do that without dragging the patient back to have a look at the lesion because you can't remember it. You've got a photo of it, you can start to pre-plan with that phone call.
Absolutely.
So, Johnny?
Yes.
So can I again emphasise the usefulness of this in interacting with the lab? There's a very famous study that Peter Sawyer was a author on, where they took pathology samples and expert histopathologists around the world and gradually added more information that they were accessing, and for example age, site, change, and then eventually dermatoscopic images, and it actually showed that for difficult lesions, the more information the dermatopathologist had, the better, and that the dermatoscopic image was vital in difficult lesions for making a final diagnosis. So it is very important. Not for 95% of the lesions, it probably doesn't make any difference. But for the 5% of lesions that are difficult and difficult to diagnose, both clinically and histologically, immensely important that we have a look at the dermoscopy. It's not to say that all the pathologists in the lab are experts in dermoscopy. We're all learning about it. You know, I happen to know a little bit more about it than some of the others because I've been in clinical work, but some of the other pathologists are not expert in dermoscopy, but they're learning. And it is a work in progress, but it is very important that we can access clinical and dermoscopic images so that we can improve the diagnosis in the lab.
Absolutely great. Well, I'll take individual questions during lunch, but we all need to get out to lunch and have some feeding. Oh, sorry, I'll take Greg's question.
Sorry, Joe, just one more. From a logistical perspective,